right, great. Topic for today is, I think, a good one to review, and that is seizures. So you have a case for us. I guess I could do a couple objectives. I forgot the slides.
Yeah, let's do the case.
Okay, go ahead.
It's getting close to July. So this is a PBL kind of format, which is a little different. It's from, I think it's Yale.
Yale curriculum.
Yale curriculum. So we'll put the PDF of this on file. So 48-year-old lady, she comes in, she passed out yesterday. She woke up like normal, she went to the bathroom. Next thing, everybody passes out in the bathroom, right? Especially old men that are trying to urinate. The next thing you know, she's on the kitchen floor. Yes, side comment, we're at the VA. 3 hours go by that she just cannot account for at all. She's originally from the Democratic Republic of the Congo. She's been living in Connecticut for the last 10 years. She had hypertension that's treated with amlodipine, but she stopped it a couple months ago. She doesn't think it's necessary. She doesn't drink, smoke. She was last sexually active 10 years ago before her husband passed away. So, since it's kind of a PBL format, we're going to throw you the question. What diagnosis should you consider with transient loss of consciousness? And I like this because this is fair. We get this, right?
Right,
You have to
we
start
do. It's a
parsing
good
this out.
differential to have. Any ideas? Throw out one.
Arrhythmia.
Arrhythmia, good.
Yeah,
Yep. So
absolutely.
a syncope from cardiogenic syncope.
Yep.
Anything else?
Vasovagal.
Vasovagal syncope. Yep.
Micturition syncope.
You love that path.
I do. Well, it's the VA. You know, you got all these old guys with big prostates.
Anything else? It's something you treat at the VA a lot. But it gives fecal seizures in the hospital.
Alcohol withdrawal seizure.
Alcohol drinking or withdrawal.
Yeah, or some drug we gave them.
So toxicology type of things. And then I think one that we don't think of very often is like migraines.
Yep.
Because it's kind of the same blocking of neuro, especially like for a partial seizure or something, not your typical tonic-clonic. How do you tell between all of these? So she passed out, she was out for
She
3
thinks
hours.
about 3 hours.
Nothing else was witnessed. She didn't lose urine. What's all of that lead you to think?
Well, not losing urine. You normally lose urine with like a true seizure, tonic-clonic seizure. So.
And they usually have like this post-ictal confusion and all that stuff. And usually syncope doesn't last for like 3 hours. Just like a transient.
Yeah, so syncope, you're not out for very long. Actually, I'm going to tell you, and I learned from this unit, is that losing urine is fake news for a good way to tell. It is. It doesn't help you differentiate seizure from
An alternate
not.
effect.
It's like, yes. How do you like that?
It's a myth.
It is
I learned
a myth.
that. I learned that too because I'd always asked.
I think
and I put great faith into that piece
I did
of data
too. I did too. Tongue biting, if it's present, it helps. If it's not, it doesn't mean a seizure didn't happen. Aura, like in a migraine. These are all kind of interesting things that I learned. Seizures have auras too. Aura is actually another seizure.
Yeah.
It's a mini seizure prior to before the electric activity kind of spreads over. And then I think the other thing that sometimes people mistake is that the convulsive movements can happen in syncope too. Because it's just from hypoxemia, lack of flow to the brain. And so they will actually convulse. But they'll actually convulse a lot more kind of as they fall down. So those are kind of interesting things I think that can help you that we've kind of assumed over for me, years.
Yeah, me too.
Yeah.
The other one I liked a lot that I think if you rotate with Dr. Singh, is he still doing his seizure? A good chunk of the people that Dr. Singh sees have pseudo-seizures is the wrong term now.
Psychiatric or psychogenic or something like that, yeah.
So a good psychiatric history, and along with that, medication, some of the psychiatric medications can cause seizures.
That's true, they lower your seizure threshold.
Yeah. And then just other things. I got a call this week from pre-op on a guy with MS.
Yeah.
And they're having a heart attack because his resting blood pressure is 170. And they're just very worried, but the problem with him is when he stands up, because he gets terrible orthostatic hypotension. Type 1 diabetics, they've been a diabetic for a long time, those kind of things too to keep in mind. And then also the code to the CT scanner, somebody gets their IV started or gets contrast and they pass out. What's that likely? Vasovagal. Or you'll get them to the lab sometimes. Somebody they'll see their blood and just So a good explanation.
Yeah, yeah.
So what do you guys want to do to further define the differential, and what history would be helpful?
Any medications?
Any medications?
Good. So medications that lower seizure threshold, tramadol. We think of that one all the time. Bupropion, venlafaxine, and I didn't realize this said penicillin.
I didn't either.
I didn't know that one.
I wanted to look that up because I can't say I've ever seen a penicillin-related seizure.
Yeah, me either.
We've used tons.
Social history, drugs and alcohol, super important. I think some of the things that we mentioned about urinary incontinence would be good history, and then psychiatric history. So she comes
No, I would say urinary incontinence is not a good history.
Right, no, I'm sorry, yes. Correct.
I beg to differ. We just said.
It was fake news. I have a
Fake
different
news.
fact. No, I agree.
Yeah, you believe in the fake news.
So she comes in and she says, you know what? She can recall prior waking up, leaving her bed. She's going to the bathroom. She had a metallic taste in her mouth. She's never lost consciousness before and reports no predisposing factors for seizure, including prior head trauma, illicit drug use, or fevers. The events immediately after are sort of foggy. She felt well the day prior to the episode and feels well now, except for she has some muscle aches. Her vital signs and physical exam are normal, and ECG is normal sinus. So the question is, what do you guys make of that metallic taste?
Anora. Yeah.
Anora, yeah.
And it's a common one for seizures. But I think unless you ask people, people aren't going to volunteer it.
Yeah.
Even people that have seizures constantly sometimes will kind of know when they're going to have one, but they can't identify it because it's very brief compared to a more prolonged aura for migraines.
So this sounds more and more like a seizure. So what workup would be appropriate?
EEG.
EEG for
Good.
seizure.
Yeah.
Yep. Still. Yep.
So-
You want to do an EEG? And anything else?
Can I throw some EEG facts in?
Please do.
I wrote these on the side. So what do you expect to get out of your EEG? So you're gonna order the test, and it should be done. It should be done in everybody with the
First 24 hours is your highest yield.
Yep. 1/3 will be abnormal. So you'll 1 in 3 you'll find an abnormal EEG, but of those with true that have epilepsy, which is 2 unprovoked seizures more than 24 hours apart, or somebody with a seizure with a risk factor like
Right.
stroke, a brain tumor,
lesion.
a high risk person. So of all those people that have the definition of epilepsy, half of them will have normal EEGs. So don't let a normal EEG say, it's probably not a
Right.
seizure, because only 1 in 3 are going to have an
Yeah,
abnormal.
not a great.
But it's
predictive
still a
value.
very important test because I think it affects, it helps with diagnosis, and it also, we'll talk about treatment. I think it helps you think about whether to start an anti-epileptic. So what other tests do you guys want to get?
You can rule out other metabolic abnormalities that might.
So what?
like
Hypoglycemia, hyperglycemia.
Yeah, although hypoglycemia I think is important to think about. By the time she's coming in,
It's
she better be normal.
She's
she's
dead.
conversive,
she's been out
right?
3 hours.
Oh, though sometimes you'll have those folks that are really low, and they'll still be talking to you.
Yeah.
Hyponatremia came to mind.
That's true.
And I think that's a good. What about the old prolactin? Oh boy, let's get a prolactin.
Yeah. We still ordered it in hospital medicine, but it's not that effective.
Very good.
Yeah.
Yeah.
You should quit ordering it,
Yeah.
really. Right? Because it can be high in syncope, and it can also be, it's a very short time window.
You have to get it within 20 minutes of the
It has a very
seizure,
Yeah.
high false
And
Good
then-
luck with that.
and then repeat 6 hours later.
Yeah.
Yeah. It's almost on the line of your cosotropin stim test. You have
Right.
to do it 3 times before you get it right.
Right.
How about anything else?
CK level, in case if it's seizing for a long time.
I think that's a good idea just for care.
Yeah.
She's
Yep.
on the floor for 3 hours.
Right.
And that's probably her muscle aches,
I
right?
want to know that she's not going to get some renal failure from some rhabdo.
And if she has any high risk thing in her social history, probably can check for HIV and all that.
Yeah, and
I think that's good for brain lesions. Infection is one thing we didn't talk about as far as
Yeah.
a cause, so
so if they have a fever,
Yeah.
definitely a CBC.
well, you
What
might
kind-
need a lumbar tap if you got a fever.
Yeah, but otherwise an LP is probably not helpful in a routine
Yeah.
case.
CT. Just rule out big things.
Oh, urine drug screen, sorry.
Usually
In the right
blood
setting,
alcohol,
right? Alcohol, blood alcohol, amphetamines, cocaine. Also, the
But you mentioned head imaging, and yes, that we should do that
Yeah.
for the first seizure. Because that has very good predictive value and going to tell you whether you want to treat somebody for a first seizure or not.
Mm-hmm.
So the rules are you usually don't. And I'm talking about unprovoked. So provoked, if they're alcoholic withdrawal, they got infection or something, that's a total different thing. So this is somebody unprovoked like her.
Yep.
If you've got something abnormal on your imaging, MRI or CT, or you have an abnormal EEG, that's when you're going to treat first seizure because their recurrence rate is much higher.
Yeah.
But they make a big deal about otherwise you don't treat it because even treating somebody after their first seizure, even if they're going to go into true epilepsy and recurrent seizures, doesn't reduce the incidence of the second seizure. So you might as well wait and see if they're going to fall into a one-time seizure or a repeat type of seizure.
Right. Neuroimaging is abnormal in 10% of folks.
That's pretty high yield, I would
Yeah,
say.
that's and definitely worth doing. So we actually faced this as a family. My brother-in-law dropped his kids off last summer to soccer practice and went to Best Buy to go get his new Apple Watch. And he sort of remembers feeling not well and tried to pull back into the parking lot. And that's all he remembers. And a witness saw him go into a generalized seizure and he hit the gas pedal and drove his car into a concrete wall. Now he's an oral maxillofacial surgeon. His EEG, all that stuff is normal. And so they called and they said, well, should Ben go on anti-epileptics? What do you guys think? So I told him it won't change.
Right.
But, so he had an unprovoked seizure. The chances of him having another seizure in the next 2 years is between 1 in 5 and 1 in 2. And the
His head imaging was there.
everything was normal. So he had normal EEG, normal all that
Unprovoked,
stuff,
yeah.
unprovoked, just an out of the blue unprovoked seizure. So the chances of him having another unprovoked seizure is between 1 in 5 and 1 in 2. And the rate of adverse events with anti-epileptics is between 1 in 20 and 1 in 3, depending on the anti-epileptic you pick.
And how much you use it.
And so I think the point was you need to look at the individual situation. For him, it's devastating. And he went on anti-epileptics because he wanted to reduce he wanted to go back to work. He didn't want to. I think you would qualify him as high risk. You don't want to have your head and neck all opened up and have your doctor on the floor. That's a bad situation for everybody. Then if you have a second seizure, your chances of having a recurrence, and
That's when it's worth treating.
yeah, then you definitely. So after the first seizure, it's patient dependent.
Yeah.
And characteristic dependent. If you have an abnormal EEG, abnormal MRI, or both, you're probably going to weigh in favor of treating.
Yeah.
Or you have somebody that has a good reason why they don't want to have another seizure. They want to take the chance of take the medicine and deal with the side effects if they develop. But if you have a second seizure, 1 in 2 to 3 out of 4 people will have
So you
another
have
one.
to treat
So you have to treat them. And okay, and so then you treat them, and then, oh my gosh, the part that the government loves, the DMV. Oh, no.
I know.
I hate this one. It makes
Yeah.
me get hypertensive. So,
But wait, we're in an easy state.
yeah,
Yeah.
oh, geez, did you click on the
I
link?
did.
Oh, I did too. Nebraska's terrible. Iowa's a little bit better.
Yeah.
So it's state dependent. Whether,
And there's a website, epilepsy.com.
yeah, and there's a
To DMV section.
DMV section. It's a really user-friendly website. You click on driving laws. It's state dependent.
So we're talking about a physician's responsibility to report. So,
Mm-hmm.
but in Nebraska and in Iowa both, you don't have to report.
Yep.
In Nebraska, you don't have to wait any amount of time to get to start driving again. In Iowa, you have to wait 6 months after the seizure to start driving.
And have a letter.
Right.
And then I think Iowa was more restrictive. I think they required you to have periodic 6-month exams for up to 2
See,
years.
but I don't think people self-report.
I don't think so either.
So
And
is the Nebraska thing new that you don't need to wait?
I don't know if it's
Because-
new.
Because we always
used
said
to
3
think like
months.
3 months.
I thought
Yeah,
3
that's,
months. California.
According to epilepsy.com.
Yeah. California is 3 months because Ben is in he's in Los Angeles and he couldn't drive for 3 months.
3
Luckily, he lives in
That's
Los Angeles and can take Uber or a taxi or whatever. But you in Nebraska, you could be in trouble. But if you think that they're driving and they're unsafe, you should probably report them, and you should be protected from HIPAA and legal repercussions. And one thing I thought was interesting, the relative risk for motor vehicle crash associated with epilepsy, so lower is better, right? 1.3 to 1.4. So we get really worked up about it, but then they gave you some others for comparison. Hearing loss, 1.19. Cardiovascular disease, 1.2. Diabetes, 1.56. Mental illness, 1.72. Alcoholism, 2.0. Med side effect, 1.7. 1.58.
So seizures aren't the worst thing.
Yeah, seizures aren't the worst thing. I don't have anything.
You want to talk about side effects of anti-epileptic drugs? I think that shows up on boards quite a bit. So
Sure.
What's a common side effect? You say you got a patient he or she's on chronic anti-epileptics. What do you need to do?
Liver. Toxicity.
Liver's important. Yep.
Cell
Many have-
count.
Hirsutism,
Cell count.
gum hyperplasia.
Cell count. Yeah.
Yep,
Gum
good.
hyperplasia with
B12
phenytoin.
folate deficiency.
Yeah. Yep.
Kidney stones,
Yep. Kidney stones with toparamax.
and almost all of them cause some demineralization.
Yeah, that's what the big thing is, that those people need DEXA scans every 2 years, starting at whenever they start seeing you. They also probably need a lot of vitamin D because a lot of them affect your vitamin D metabolism.
Mm-hmm.
That's actually the mechanism of demineralization. They're also teratogenic, a lot of teratogenic during
Antifolic.
pregnancy, so you want to watch out for that. Some of them. We don't necessarily treat to the levels that are prescribed. We treat to the levels that prevent seizures, but you got to start watching for gait abnormalities, dizziness, sedation.
Some of them can cause orthostatic changes.
So that people can fall quite a bit with bad bone density.
Yep.
So. But I think that's it. Oh, that's our song.
Yeah, it's our sign. Saved by the bell. Unless you
Oh, I
guys,
like it.
we'll have questions if you guys want them.